to meet you. We're live. Hi. Hi. Thank you for coming, Doc, and thank you for staying. For those of you who are watching live and replay, this is Dr. Olabintan, CEO and co-founder of Livingspring Family Medical Center. We started off late. That was my fault. Apparently, I was covering the window through my camera. I didn't figure it out so late. But we're here, and we're doing another topic today on Doc. I've been on many medications for depression, and it hasn't worked for me. Are there other options? And I have the one and the only Dr. Teresa Anderson, who is not only a friend, a colleague, but also a champion when it comes to helping people thrive and improve their quality of life, those who struggle with depression and other mental health conditions. But I'm going to stop now and just have you kindly introduce yourself, Doc. Who are you and what do you do?
Thank you so much, Doc. So my name is Dr. Teresa Anderson, and I run the Anderson Clinic in Cincinnati, Ohio. I've been in practice for about 13 years. I'm an outpatient adult psychiatrist, and we treat treatment-resistant depression, anxiety, and PTSD mainly. And so I offer psychotherapy and medication management, which is your standard traditional offerings of most psychiatrists. But I also, 7 years ago, we started offering ketamine infusions. We were the first in the state of Ohio to do that. And then 4 years ago, we've been offering PrTMS, which is a personalized EEG-guided version of transcranial magnetic stimulation.
Awesome. Awesome. I love what you do. And I wanted to highlight they're first. Did you say that already? You're first to offer ketamine infusion in the state of Ohio, and one of only 12 clinics in the whole country that's offering PrTMS. And I like what you do. I love what you do, actually, that you help patients who have treatment-resistant depression, even those who don't. But this is something you specialize in, because I've seen that quite a few times with clients, and I know how much of a struggle it is when you've tried everything and you feel like it hasn't worked. But I'm not going to jump to the topic too quickly. My next question to you, Doc, is why do you do what you do? What got you in this field?
So I love people's stories. I'm a very literary person. And so whenever somebody comes and talks to me about their lives, I feel like it's the next chapter in a book that I'm reading that it's my favorite. Right? But I fell in love with this particular aspect of psychiatry when I was working at the VA. Part of our training at University of Cincinnati involved working at the VA with veterans who suffered with PTSD. And part of what was just amazing to me is there are folks who underwent just unspeakable horrors and traumas, and, you know, watching friends and loved ones get blown up, and they were privy to and witnessed and experienced some just awful trauma, but that didn't kill them. What was killing them was the stories they were telling themselves about the trauma. And it was how they internalized that trauma and how they made it a judgment against themselves. If I were a better person, I could have saved them. If I only did such and such earlier, then this wouldn't have happened. If I, like, all the things that they, like, all the judgments that they were sort of weighing on themselves, like Atlas, you know, with the world on his shoulders. That's what really was killing them, the stories that they were telling about themselves, not the actual trauma itself. And so when we worked through those stories and learned to question the judgments they were making based on the trauma, they had amazing turnarounds. And to me, that was just awe-inspiring.
Wow. I like how you talk about the stories of people as a book. And it's not really excited about. You want to see what's going to happen. You want to see how you can help them. And I love that in the process of caring for your patients, you are digging and finding out, okay, well, where's the disconnect? Where's the issue? Yeah, the trauma is one, but also how the story is being played as to what happened in their mind. That's a challenge. So, yeah, I was sitting there staring at you like, wow, that's profound. So thank you for what you do. I love what you do. I've been following your work. I'm a stalker, you know, just seeing what you do. I'm like, ooh, she has another video. So I really love what you do, and I appreciate what you do. So next question, and the first next question I'm going to ask is depression. So we're talking about depression. What is depression for someone who's not so technical? Who's like, okay, what does that mean? Wow.
Okay, so depression is feeling down and feeling worse than feeling better more often than not, at least consistently for 2 weeks, where your sleep is affected, your appetite is affected, your ability to perform daily tasks of living, we call them ADLs, activities of daily living, like showering, going to the grocery store, paying bills, that sort of thing. It's affecting your work life, your social life. You may be isolating. You may have some anxiety with it as well. You may not be taking care of yourself physically as much. And in some cases, people may be feeling like they want to hurt themselves.
Okay. Thank you for making that so easy to understand, and the relationship to the quality of life and affecting the daily actions or activity of daily living. Now, one of the common questions I get, or we get, in taking care of patients is, okay, yes, there's the diagnosis, depression. I've started a medicine. How soon would you say you expect the medications to work, generally speaking?
Well, that depends on the medication. A lot of general SSRIs can take sometimes 6 to 8 weeks before they start working. Some of the medications like SNRIs, the ones that work with norepinephrine, sometimes take as little as 2 weeks. Some of the newer medications out, like Auvelity, that has working on the NMDA receptors, can be as little as 2 weeks for remission. So it very much depends on the medication that you're choosing and the patient's response to it. Now, the problem being that we can't just start out right off the gate at the level that we think that you might need. We have to kind of go slow and work our way up to that point. And sometimes that involves tolerating side effects, tolerating wait time before you feel better. Can't wait for that.
So the point is, it takes time, and of course our patients, we want them to feel better as soon as possible. Like we take them like, hey, but it takes time. And so being patient with the course, for someone who's watching, who may have started some medication, being patient with the course, and of course coordinate with your own psychiatrist, primary caregiver, as to what the next steps are and how soon to follow up. Now, next question I have is this. All right, is it possible to find out what medications would work for you? So I have a client who's asking, or a patient who's watching and who's saying, you know what, how do you know which one to start off with? What would you say to that question?
So as a clinician, we do our best to try to match the symptom profile with what the medications do. For instance, I wouldn't start a super anxious person on Wellbutrin, for instance, because it's super activating. But I would start that on somebody who was sleeping all the time and eating too much and felt lethargic and unmotivated. So we do our best to try to match the symptom profile with what we know what the medications do, right? But if you've tried several and nothing's worked for you, or if you had a lot of sensitivities or side effects or allergies, one way to try to narrow it down a little bit would be the gene site test. I don't recommend that for everybody necessarily. And it doesn't, I think there's a misnomer in terms of the public eye. I believe they think that, oh, well, I took this gene site test and it tells me what I should be on. That's not the case. And so the way the results come out actually is they profile your particular receptors in your brain, and they cross-reference it with the type of liver enzymes that you have to process that medication. And they cross-reference that with the drug and what it does and how it's processed. And so it comes out in a page of green light, yellow light, red light. And so the green light drugs are the ones that are safest for you to take, least likely to give you side effects, but won't necessarily work. The yellow light is okay with caution. Like sometimes you're a really super fast metabolizer, so you need a higher dose of it, or you're a super slow metabolizer and you need a lower dose of it, or you need to be careful of side effects for whatever reason. And the red light, that doesn't mean it's off the table. It just means that you have to be more careful about how you go about it. So.
Good to know. So they're suggestions. They're not absolutes, especially when it comes to effectiveness of it. Good to know. Next question is, you have someone who's tried everything, the different classes, the atypicals, the antipsychotic, like has been to multiple, and they're frustrated and they're like, I guess it's something that they have to live with. What would you say to that person?
That's definitely a person
medicine on it, and nothing has seemed to work. Yeah.
That's definitely a person that I would recommend looking into either ketamine or PrTMS therapy. The ketamine can offer almost immediate relief of symptoms. Sometimes it takes 2 or 3 infusions, but 2 or 3 days versus 2 or 3 weeks to feel better is a lot more advantageous for folks who are kind of on the verge. Now, there's good and bad points to this. Okay. Nothing is a panacea.
Right.
You still have to do the work. You still have to go to therapy. You still have to take your medications. You still have to participate. There's no magic wand. I'm all about Harry Potter, but we can't just poof you into being better and keeping you there. So ketamine can make you feel better for days to weeks to months, depending on the person, but you'll probably need boosters. And people are very upset when they hear that because they're like, oh my gosh, I'm spending this money. I'm doing this ketamine and I thought this was supposed to work forever. Well, if you're training for a marathon and the marathon's over, you're like, okay, well, I've done enough exercise for the rest of my life.
Good analogy.
You still have to repeat. So the way that it's given is 6 infusions over the course of about 2 weeks. And you might need booster infusions, like a single 1 or 2 infusions every 6 to 8 weeks, depending on your symptoms. We give folks a tracking guide to keep track of their symptoms. PHQ-9 for depression and GAD-7 for anxiety, PCL-5 for PTSD. And they need to take those little questionnaires once a week. And if they see their scores steadily climbing over the course of 2 weeks or jumping a level of severity, that's a time to kind of come back to us and get another booster infusion.
Okay. This is very, very, very useful, insightful information. I have one more question, though. Someone who's wondering, would insurance cover this? Was it something I want to invest in? What would you say to that? Is it typically covered by insurance?
Insurance doesn't typically cover ketamine because it's off-label usage for depression. Now, it went generic in the 1970s, and so therefore any company who does research on it is not going to benefit because anybody who produces chemicals can produce ketamine. So they tweak the molecule and try to offer it intranasally, and it doesn't work as well and all that kind of good stuff. But it intravenously is not covered by insurance, but PrTMS frequently is because it's still under the umbrella of standard TMS. And as long as you carry a diagnosis of treatment-resistant depression and you have been tried on and have failed at least 3 separate antidepressant agents, most insurances outside of Medicare and Medicaid will play ball and cover part or all of the cost of 36 treatments.
Okay. Good to know. Good to know that there are options. For someone who's watching, I would encourage you to remain an advocate for your own mental health and connect with a clinician like Dr. Anderson, who offer more options to help improve the quality and quantity of life. And on that note, Doc, I have someone who's watching, or people who are going to watch this hashtag live, hashtag replay, who are wondering, well, how can I connect to this one center in Ohio and one of the few that offer these options actually to clients like themselves? Where can people connect with you, Doc?
Absolutely. So you can find us online at www.andersonclinic.net. If you're in the area, you can give us a call at 513-321-1753. And if you're into podcasts, we offer on Apple and Spotify Psych Waves.
I love it. I love it. And we're going to have all that information in the comment section so people can connect with you either as a speaker or to connect with you for care. But I really appreciate you for coming on time and for waiting it out. Thank you so much, Doc. I appreciate you.
And if just in case, and if anybody else is in like another state or another area is interested in PrTMS, Dr. Murphy, the inventor of this technology, is based out of San Diego, and his website, www.prtms.com, will show you a list of clinicians available in your area.
Oh, wow. Awesome. 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 Thank you for providing that information. Be sure to share that as well. And for those of you who are watching live and replay, thank you for joining. Please share this with someone who could find this useful. Remember, these are medical suggestions. We do encourage you to reach out to your primary care doctor, reach out to your psychiatrist to find out an individualized plan for you, and to ask questions like these, like, you know, is this an option for me if you've tried multiple medications in the past? This is the voice again of Dr. Olabintan. And if you are looking for a thorough, passionate, and a caring family physician in the Mansfield, Texas area, I am she. Thank you for watching and have a good one. Bye.